Good afternoon, this is Julie Coxon, and welcome to this week's Webinar Wednesday with Dr. Cox, and his third in a series of specific condition application of flexion distraction protocols. This week's focus is on disc degeneration of the lumbar spine, and the handouts are available through your handout panel, so please check those out. I'm going to turn this over now to Dr. James Cox, developer of Cox Technique, for this week's discussion.
Probably this course will be the most common thing you and I treat on a daily basis, at least many of us. That is degenerative disc disease of the lumbar spine. When you realize that only 1% of people go to surgery, that means 99% of them are going to seek some form of non-surgical care, including chiropractic. This is one of the biggies. Spondylosis of the lumbar spine, with or without spinal stenosis. At the beginning, these are a two-page document of the protocols, protocol 1 and 2 of treating lumbar spondylosis. Protocol 1, those with radicular pain. Protocol 2, without radicular pain. I'm not going to go over these. I'm going to cover them as I show you technique. You can read these, keep them if you wish to utilize them in studying and administering this form of manipulation. Again, I like to begin with some of the science behind these studies. This was done at Palmer College, published in Evidence-Based Complementary and Alternative Medicine in 2015 on the anti-nociceptive effects of Cox Technique. And they were using the Worcester rat model. The paper was published here, and it studied the treatment, our treatment on neuropathic pain, the treatment of both hyper and hypomobility, and we utilized the instrument for the human and 1/12 the size of the Cox 8 human treatment instrument for treating the big Worcester rat. This is low velocity variable amplitude spinal manipulation, as opposed to high velocity, low amplitude spinal manipulation. As you know, some people cavitate, some people can tolerate the lumbar roll, some cannot. Therefore, you and I need different approaches of spine manipulation and mobilization depending upon patient requirements. So let's study together about how we treat with Cox distraction manipulation. Why do we distract people before we manipulate them with my work? Well, when you look at this paper by Chow, published in 2017 in Musculoskeletal Science Practice, you saw that on lumbar MRI studies on the mechanical effects of distracting a spine showed that it is effective in increasing the disc height. That is to reduce the compressive effects of gravity, particularly in the posterior disc, where the herniation, the stenotic change, the changes in the ligamentum flavum, the end plate hypertrophy, the facet arthrosis, all combine to create spinal stenosis. We distract before we place joints through other normal physiological ranges of motion in order to reduce stenosis. So that as we place the joint into other ranges of motion, we have reduced stenosis and basically decreased greatly the chance that lateral flexion or rotation would create a stenotic effect on the dorsal root ganglion and perhaps even the distal nerve roots. Jun put it this way. It's published in March last year. The mechanisms of lumbar spine stiffness change following spinal manipulative therapy. Pointed out that these are the changes that take place with spinal manipulation. We change muscle activity. We know by the work of Wong and Kauchuk that one visit created strengthening of the multifidus muscle that lasted for what, 7 days. We increased mobility, range of motion. We decrease pain and we increase the patient's tolerance to pressure pain thresholds. We change the change of the myofascial trigger points, and we change the central nervous system by creating normal excitatory afferentation of the lateral spinal thalamic tracts and the posterior tracts of proprioception of gull and burdock. Consider the research work of Gudavale, Cox, Cruz, Olding, and Yoakum, done at the Loyola Medical Center, a published paper in the Heinz VA Hospital with collaboration of national and Palmer universities, that the changes that take place within the spine when you apply Cox distraction spine manipulation are the following. We increase disc space height, we increase the foraminal area by 28%, we drop the intradiscal pressures up to 192 millimeters of mercury, we restore and maximize to the best of that patient's capability their range of motion. And fifth, we create positive afferentation. That is, the normal excitatory reflex is done by stimulating mechanoreceptors as they carry via the spinal thalamic tracts and the posterior tracts to the somatosensory cortex, creating the pyramidal system in the corticospinal tracts to bring down the endorphins, increase serotonin for the relief of pain. And put another way, think about this. Whenever we do our technique on a spine, as Wong and others said, in order to have reduction of pain and disability following a single spine manipulation, these following changes must take place in the spine. Number one, you must increase range of motion. That is, decrease spinal stiffness. Number two, strengthen muscles. I referred to this paper on strengthening multifidus before. Beati said, you must increase the imbibition of fluids from the cancellous vertebral body through the end plate into the nucleus of the disc. And we know that today by the work of diffusion weighted imaging as apparent diffusion coefficient. And then Kuo wrote this paper about distraction. And he pointed out that when you and I distract a spine, it is effective in enhancing the nutrition supply to the disc while promoting, and these are his words from this paper, promoting disc cell proliferation of the degraded discs. Now, you've all seen these papers. We present them in didactics all the time. This is Discat Plus. This is chondroitin sulfate from the pernicatilicus, a green lip muscle, the most powerful known source of glycosaminoglycan. That is the chemical in the nucleus that imbibes fluids to create its turgor. This is the most powerful enhancer and synthesizer of glycosaminoglycan made today. Give it to the patient as we are performing the manipulation you are about to see. And then remember the work of Chung from Radiology Journal. When we do distraction, we change the shape of the disc, we increase the disc space, we reduce the intervertebral disc herniation, we separate the disc, making room for the nerve roots and the DRG, and we widen the facet joint space. So when you and I go to the instrument and we treat these spines, and you and I treat these all day, every day, am I right? This is what we do. Many of these people can tolerate lumbar roll, PA thrust. Many of them cannot. The reason, therefore, that we offer this technique, which is how I treat spines like this all through my career, and many of our people who we train and certify do this in their clinic every day. Some of these will not tolerate a lumbar roll. They will not cavitate. They have no nitrogen gas. These big claw spurs are ankylosed, and you can't cavitate them. They have spinal stenosis at multiple levels. And when we distract, remember that we open disc space, we drop intradiscal pressure, we tauten the ligamentum flavum, we give the best sagittal diameter of the vertebral canal that we can attain before we place these faucet joints into their physiological range of motion to create what? Positive afferentation. I would like to introduce you to this textbook, and I suggest to our people, I don't think, some of them do it, read it 3 times, cover to cover. This is the book that covers all of our work. It's written by 6 other authors. I did 10 of the chapters, other authors did 6. This is the very basis, the science behind this technique. Incidentally, this is published by Lippincott, Williamson, Wilkins. All the royalties from this book go to spine research. That, along with my donation to Kaiser every year, pays for doing spine research to build our profession's image as the leader in spine manipulation. Let's move to the instrument and cover how we treat degenerative lumbar disc disease.
Ready? When I begin with treating these degenerative disc disease, oftentimes throughout the entire lumbar, even the lower thoracic spine, I begin tolerance testing well up into the lower thoracics. Thenar on the spinous, just apply flexion, and I'd ask you to look at the force I'm using. If you'll look, I'm applying 2 pounds per segment. So I start up around T8, T9, and just move down 1 segment at a time, asking the patient with degenerative disc disease if this causes them any pain. Typically they say no. In fact, many say it actually feels good to have my spine pulled apart. So once we tolerance test, and we're going to treat the patient who has no radicular pain, no stenotic disc herniation or degenerative change, but just degenerative changes throughout the lumbar spine, the most common thing you and I probably treat every day as clinicians. I will begin by applying and testing automated distraction. Now note that as I apply automated distraction, that I'm applying up to 15 pounds of traction to this spine. But realize I'm treating an entire thoracolumbar spine. So as I move down the individual, I will decrease that force. I've already tolerance tested doing it manually, so I know that it's not of any pain production to my patient. So I distract each of these segments, remembering that I'm opening the disc space, increasing foraminal area, dropping intradiscal pressure, and then as I perform distraction to reduce stenosis, I can do one of 2 things. I can bring the patient into a distraction force. That is to say, I will make a contact in the lower thoracic, distract until I feel good tautness of the lumbar spine, and then while under the tautness, release lateral flexion and perform flexion and lateral flexion in a smooth, rhythmical, coupled pattern at each segment, realizing I have reduced stenosis, and now I can place the patient into lateral flexion to move facets, create afferentation at each of these lumbar segments. Now, I can do that manually as well as electrically, but if I use automated, it would look like this: distraction and lateral flexion in a smooth rhythmical pattern. But you'll note that when I use automated distraction, I'm applying a lot more force. In fact, I'm going here almost 20 to 25 pounds of force as I apply distraction and lateral flexion in a smooth, rhythmical, coupled pattern. Now, there's another procedure I'd like to share with you in treating degenerative disc disease of the lumbar spine. And that is to lock all of the instruments. Set the instrument to automated. The computer is now turned on. And I'm going to apply long Y-axis distraction to my patient. And while I do that, I can come in with a contact, hold, and apply the distraction at a specific level so as to create distraction of that entire lumbar spine by holding my contact as the instrument applies long Y-axis distraction. I can isolate this per a segment, say L5S1. If I come down and contact L5, I can apply specific level automated distraction at the L5S1 disc. Now this is only done after careful tolerance testing manually and then when applying long Y-axis distraction. I can also, with this patient, stop it at neutral. I can apply a thoracic restraint. And isolate this distraction to a given segment of the spine or column of the human spine. So by bringing this above the level that I want to apply long Y-axis distraction, I can set the computer to automation to pull to a specific level. I like 25 pounds for a thoracolumbar spine in degenerative disc disease. Carefully tolerance testing the patient, I turn the instrument on, palpate the interspinous spaces so as to feel the increase in the interspinous space as distraction is applied. As a patient shows good tolerance to this technique, I'm going to increase the hysteresis and creep within the intervertebral disc. That is, if I hold the spine under distraction, I enhance the imbibition of fluids from the cancellous vertebral bone through the end plate into the disc and stimulate mechanoreceptors. So it would look like this. If I press this button, it will now hold for 1 second under distraction. I press again, it'll hold 2 seconds, which is what I use. And so I'm distracting, holding the spine under distraction at the levels below my thoracic restraint. This will enhance imbibition of fluid and stimulate mechanoreceptors. I can also apply electrical currents. Say I wanted to put tetanizing current on the paravertebral muscles to stimulate and relax muscle tightness and stimulate myofascial trigger points. I can apply that electrical current under long Y-axis distraction and also apply lateral flexion as long Y-axis is delivered. So we will have the ability, either manually or under automated distraction and careful tolerance testing, to apply long Y-axis distraction, physiological range of motion that we call Protocol 2 in a non-radicular patient for the treatment of degenerative disc disease. When you look at this and you consider that many of the patients will not tolerate high velocity technique. This is another alternative complementary form of spinal manipulation, one which I use strictly in clinical practice throughout my career. At the end of this, I'd like to make a comment to you that when you were treating back pain, use curcumin, tumeric root. This is an anti-inflammatory agent that we use in treating back pain, whether acute, subacute, or chronic, to lower chemical inflammatory changes. That is interleukin 1B, interleukin 6, tumor necrosis factor alpha, and hopefully to enhance interleukin 10, the anti-inflammatory cytokine. When you're using this work, here is a pamphlet you can show to patients or other physicians in your community that fully describes what this form of manipulation is. It describes the definition of Cox distraction. It describes the research, federally funded and privately funded, that enhance and show the benefit of this type of care. We live in a time of evidence-based clinical practice. That's what we strive for. Show the evidence base, which is research, clinical expertise, and patient preference for a technique. That's evidence-based clinical practice. So I suggest that you look into those types of things. Give the patient books like Low Back and Leg Pain. It explains the causes: spondylolisthesis, degenerative disc disease, degenerative scoliosis, pregnancy, spinal stenosis, transitional vertebra, degenerative spondylolisthesis, so the patient understands their problem, how this application of manipulation benefits them. And the same thing is available for neck, shoulder, and arm pain. The better the patient understands their condition, and they understand that we don't always 100% cure them, that 30% relief is a good clinical result. And our goal is always 50% relief within 1 to 2 months of care. Once they understand that and you have good cooperation, we get the best clinical outcomes. And this for spinal stenosis. Spinal stenosis is taking over your practice, doctor, because of people like me. Anyone over age 45 to 50, the development of spinal stenosis creating low back and leg pain is certainly phagocytosing our practices. I have an upcoming seminar, a short symposium like this, to share with you on the treatment of lumbar and cervical spine, disc herniation, and stenosis. I hope that this gives you a very brief intro to our work, perhaps enhances some of you who are never heard of it before to want to see if this would complement your clinical results as well. Julie will tell you about courses with certified instructors from National who teach this. If you're interested in it and ever wish to study with me individually, just contact me for that. That concludes my part.
All right. You did very well, covered all that. And just wanted to let you know our upcoming webinars will be April 7th. April's going to be the disc herniation month, so we'll do lumbar spine on April 7th. April 21, we'll do the cervical spine disc herniation. There are more courses online if you want to get some good overviews of lumbar spine. We have research, patient cases, a lot of different courses, 168 courses to choose from. They're all about an hour online at the coxtechnique.digitalchalk.com learning management system for CE credits. Check out the textbook too, it takes you through all the different conditions. I think this series is giving you a little more on the guided specific condition treatment protocols. We have live workshops, online CE, and live seminars. The big one coming up in April will be part 4 on thoracic spine. Then we'll have a lumbar spine part 1 and 2 course at the end of April, and cervical in July, and extremity sport and rehab in September. So we have some new courses coming for you as well. Please contact Amanda at Haven Innovation, Haven Medical. They have designed and keep revising the force table for implementation at seminars for training and for patient demonstration in your office. And these are ways you can get in touch with us. Certainly the coxtrc.com is where you can get all the supplements, brochures, books, and such, coxtechnique.com for everything else. So we look forward to seeing you at a seminar soon.
Can I say
Certainly
one more?
visit our physician referral directory too online. I get a lot of calls for that. So thank you for joining us today.
I have one more comment to you. I can't stress enough about the research being done on disc regeneration. It's not there, but we have been using chondroitin sulfate from Pernican liculus since 1966, long before most of you ever heard of it. And today there is a flyer with 82 references on what chondroitin sulfate does, not only for the intervertebral disc, but on lowering the chance of colorectal cancer. I mean, to not look at this and share this with patients so they know is, to me, is to deprive our patients and us of the best clinical results that we can get. Thank you.
I think we're good there for today. The enthusiasm comes through. Certainly everything we do and everything Dr. Cox does is based on research. So please contact with any questions. Be sure you got your handouts downloaded. If you have any follow-up, just email me. We'll be sure and get back with you. Thanks again for joining us today, and see you next time.